And I can't even find how I get, so all the more you have to read it, Kim, the chat. I can't find how to get to that.
So welcome everyone. We'll get started in just another minute. All right, so it's noon on my clock, so we will go ahead and get started. So good afternoon or good morning, depending on what part of the country you're in, and thank you for joining us for the first session of the 2021 Summer Webinar Series hosted by the Third Age Committee of New York State. We are a voluntary committee of providers and educators across New York State committed to advocating for and spreading awareness of the needs of older adults with intellectual and developmental disabilities, or IDD. My name is Laura Robinson, and I'm the program coordinator for the Finger Lakes Geriatric Education Center at the University of Rochester in Rochester, New York, and the current chair of the New York State Third Age Committee. My co-chair or co-host today is Kim Andrews, and she is an incident investigator at Schenectady ARC and the secretary of the Third Age Committee. And we are very glad that you could join us today. So before we begin and go to Dr. Bishop, a few housekeeping items. There are two important buttons on your Zoom toolbar. Please use the chat, and that will allow you to type hello and introduce yourself with a name, job title, agency, and location. And we have people from across the country joining us today. And then the Q&A button will allow you to type a question in for the presenter. And we ask that you use this button at any time during the presentation to ask a question so that the question does not get lost in the chat. And we can address questions as we go along. So if Dr. Bishop wants to take a break and see if there's questions, we can do them then, or we can wait until the end of the session. So anytime you have a question, put it in the Q&A. So our featured speaker today is Dr. Kathie Bishop, who I've had the pleasure of knowing for many, many years. And Dr. Bishop has over 40 years experience in the developmental disabilities field and over 20 as a gerontologist with a specialty in aging with developmental disabilities. She has both a bachelor's and a master's in special education and a doctorate from Syracuse University in aging with disabilities. Dr. Bishop works as a consultant for many organizations in the aging and IDD networks to assist with program and support planning, as well as teachers, as well as she teaches at the Utica College online courses in aging with disabilities. She is retired from the University of Rochester and from the New York State Office for People with Developmental Disabilities. Dr. Bishop is the co-chair of the NTG, or National Task Group, Education and Training Committee, vice president for the NTG, and co-chair of the advisory body, and a member of the executive and board. She has been an active member of the NTG since inception, and Dr. Bishop has been presenting the two-day NTG Dementia Capable Care for Adults with IDD and Dementia Foundational Training with the third day Train the Trainer. And in this capacity, she has had the opportunity to train over 3,000 attendees of the two-day training and over 800 attendees of the third day training who became NTG affiliated regional trainers. So with that, I will now turn the program over to Dr. Bishop.
Thank you, Laura. And it's hard to think about how many years we've been together. Many, many years as the Third Age Committee has existed. Welcome to Thriving in a New Normal, Redefining the Future for Older Adults with IDD. Back to the Future, Ways to Move Forward by Understanding Our Past. I have to tell you, I feel like I have never presented before. I've been more anxious about this presentation than many that I have done in the past. And I have changed it. In fact, up until 5 minutes before this started, I was still changing the presentation. So I hope it's something that will be useful. Just wanted you to think of some of the background statistics. The Third Age Committee has now been over 25 years in existence. And I actually began with the University of Rochester School of Medicine and Dentistry, what was then the training program on aging and developmental disabilities at the UCED. Currently, we're looking at statistics now of about 20% of individuals, or at least this was 25 years ago, with MRDD are over the age of 60 in New York State. That was the terminology we used when third age began. Another 20% were between the ages of 45 and 60, with the fastest growing population, the aging boomers. Again, this is when third age started. We are here today. And New York State was far ahead of most states in the country with this happening. In many of the New York State agencies and organizations, approximately 20% of the workforce will be of retirement age. Actually, by now, we're looking at least 50% of the workforce has turned over in New York State in the field of IDD. And a huge percentage of people with MRDD who are unknown to the disability organization. That still continues today, even though we use different criteria, diagnostic criteria, and different terminology. The objectives for today are to help you ask the tough questions to make a positive difference for today and tomorrow. And I want you to think about, what did you learn about the past that can help you make a positive difference for tomorrow? And from what you learned, how can you use this information to make a specific positive change? And I have an assignment for you that I hope you'll be able to share at the end of this, at least think about. And also would be happy if you would send to Laura or to myself on the first slide, the bizbur1@earthlink.net email was there, of what questions you came up with, because those will be excellent questions for us to think about in the third age and other organizations of how we can help make a better future. I wanted to play this morning, but I knew if I did play this song, I'd probably start crying. And so I use this song because I want you to think differently, to see the world with different eyes, and to learn to ask the questions you never thought to ask. And this is a short part of the verse. You think you own whatever land you land on, that it's just a dead thing you can claim. But I know every rock and tree and creature has a spirit, has a name. You think the only people who are the people who look and think like you. But if you walk the footsteps of a stranger, you'll learn things you never knew you never knew. And that's what I hope you'll think about today. I was pleased as I did research and created this. I learned things that I never knew and developed new questions. So I hope that you will ask the questions you never knew to ask to help make a better tomorrow for everyone. And the importance of knowing our history makes a difference for the present and the future. We need to make ourselves and our contributions visible. This is in the human service field. We need to make sure that people we help support, advocate with and for, become visible, become part of the planning, and become essential with their contributions recognized as part of the future that we're moving into. To decrease our feelings of isolation from the past and the people of the present. That's extremely important after COVID. In my very long lifetime, compared to most of you on the phone or on the webinar, I have never been as isolated and sitting still and less movement and less traveling and moving places than what happened in the past year with what happened because of COVID. We need to recognize our mentors, our heroines, and our heroes who were there before us, to learn from them, to help make the future the better future, and to help us to know what is possible in the present to move forward to increasing possibilities. So let's start with terminology. Our language is extremely important, the terminology we use. Think about the social context of terminology. The words we use reflect who we are as a society. If you think back to words that you were not allowed to use and were considered taboo, or words that were common terminology that were acceptable that now have become words of disrepute, of insult, Over time, for example, and today we're looking at, instead of using resident, we use more to the word individual. Consumer, putting the person before the disability, has all changed over time, and there are important reasons why. Terminology is extremely important because it creates visual pictures of a person, of a place. It makes us think in the context of what is today. We can add value or take away value by how we speak about a person, an event, an organization. And so the language we use, the terminology we use is so important. If we devalue people, the words we use today will be considered dehumanizing tomorrow. Now we have changed, and I'll talk about examples of that in a second. Some of the basic words to the use of intellectual and developmental disabilities today. I guarantee you in 10 to 15 years, those words will, if we continue with the attitude we have today, and with some of the devaluing that we do, though it certainly has improved, that those will become words that we'll want to change because they've taken on negative connotations. Let's look at some of the words compared today. Mental retardation to intellectual disabilities. Changes in criteria for diagnosis. Understand, we'll talk about this in more detail. MR evolved from moron, idiot, imbecile, vegetable. These were all diagnostic terms. They were terms we used in charts, and they were terms we used in meetings to describe people. Understand they were acceptable. They were considered that you understood the people you were trying to support and work with. But they look at how they become today. Think about the changes. Autism spectrum disorder. Autism is a problem with the family, as a brain disorder instead of a sensory challenge, sensory processing issue. Terms like mongoloid were used, extremely ethnic, racist terminology, xenophobia, to using Down syndrome today. For a while, it was Down's syndrome, as though somehow people with the syndrome were owned by someone. By the way, there was no criteria for placement in state schools, custodial asylums, which many of them were called around the country, county poorhouses, or the indigent. All of these terms have become terminology of insult. One of the first documented terms to talk about people with intellectual disabilities that we see as one of the oldest was cretin, which was French for Christian, and the implication that people with IDD were still human, able to be religious and deserving of our care. If we call someone today a cretin, we can see that would not be a welcome term to use. Idiot. 2 years or less, sorry, I left off the 2, of IQ, profound mental retardation, and considered probably inherited. And we'll talk about eugenics movement in a minute. Imbecile, moderate or severe. Now remember, these are diagnostic terms accepted and used. These were not just simple words you threw out. These were terms you used if you had a case review, for example, which is what they were called. These words would be used to describe the level of intellectual disability, would be used to describe and help figure out ways of support. And it was accepted that these terms were used. Imbecile was moderate or severe. Moron, or typically in the UK, this feeble-mindedness was a substitute for the term moron. Mild mental retardation, and not necessarily inherited. Amnesia, people who were born with disabilities, and this is where the word dementia involves from, who are people who acquired mental deficiency later in life. So this was a diagnostic term used in a way to describe people as well. And interesting, the challenges we have in treating dementia today in the general population, not just with people with IDD. Mongolism, it was because of the facial features that are that are shared by many people, especially those who express 100% of chromosome 21, the trisomy 21 in every cell of the body. And it was a very racist term used, but it was accepted for many years. And if you go back and look at old records, you will see all of these terms used at one time or another. Educational terms, when I began as a special education teacher, which tells you how old I am, or gives a sense of it. Educable, trainable, profound. And profound meant that there really was not an ability to educate. There was not hope. And even as we did deinstitutionalization, there was a priority of who was deinstitutionalized based on what level they fell in these terms, educable, trainable, or profound, with a thought in the beginning years of deinstitutionalization, beginning years, that there would be people who never could be moved from an institution into home or community settings. The word retarded was recorded first in 1426, and it meant mentally deficient or delayed, and could be diagnosed at birth or might be diagnosed shortly after, if it was diagnosis. But none of this criteria was used for placement in state schools. It could be that the family, and often was, very poor, large family, many, many stories of people with cerebral palsy, for example, who mom couldn't care for the 9 or 10 children in the place in the state school, with the promise that it was a school and they would be able to provide better care, even though that was a false promise. It was how families lived with the decision to place. The eugenics movement is very much behind how we think about intellectual and developmental disabilities today. It has caused great, great harm. It was a political and social movement, and it was part of, very much related to development of Christianity worldwide, and something to be handed down on from age to age. The report of the president of the American Eugenics Society in 1926, Francis Galton, states in this report, Francis Galton, who was the father of eugenics, he was the cousin to Charles Darwin, from Greek for good birth. That's literally what the term means. Means good and bad birth, the full name eugenics. And it was a science of improving human stock to give the more suitable races, we detect racism here possibly, a better chance of prevailing, moved from hard science to a form of religion over time. One of the first ways it started to determine this was by measuring head and brain circumference, assuming if the head was large, the brain was too. But it has been proven today that many of the sizes were changed to justify the claiming the racial component of the eugenics movement. And if you were other than white male, you could count on that the measurement of the head and circumference for the brain would be lower, and the charts were purposely made that way. Also, throughout the eugenics movement, there was obvious changing not only of measures, also of photos. And this was some of the beginning movement, which began much of it in the UK and spread to other countries of the world, including the US, the Nazi movement that began in the late 1920s, 30s that began. One of the basic studies was a study that was conducted by Goddard, and it was the Kallikak family, which has done more to influence the field of IDD probably than most studies. And it was a study in the heredity of feeble-mindedness. It was completed in 1914, I believe. I can't see if it's 1914 or 1911 and don't remember. And it was a study of a family called Kallikak. It was not the actual family. They actually used a different name, but it was based on a man of considered of high intelligence, and his family of high repute, who married a woman of high society, but had a family and had a mistress who was considered of low society and considered called what words were used for prostitute of the day. And by his mistress, he had many, many children. And so that line of his was studied and compared to the line of the children, the fewer children that he had with his wife, who was considered of high society and considered a very good Christian, whereas his mistress was not. It has been proven today that the photos that were used for comparisons, the measurements and statistics used were falsified, and it was made to look that the 100% of the family from his mistress were criminals at the time of someone who was mentally retarded or was an idiot or imbecile, actually the terminology used at that time, or moron, though that again was the diagnostic terminology, and that all of the children from his wife were lawyers, physicians, had high standings in society, or they married into families that were of high standing. It has been shown and proven that much of this was falsified and intended to prove what he started out to intend in the first place, but we still live with the concepts of this study today. We see here a sign 1907, the Indiana eugenics law that was enforced sterilization for people who were considered of ill repute, which would have included people who were diagnosed as morons, had epilepsy, for example, were maybe delivered outside of marriage. And so there was forced sterilization for those people who were at risk to society. And the repeal of this did not happen, the sterilization laws, until 1974, and not enacted until 1977. For those of us, especially my age, that is not very long ago. And so it had enforced sterilization. And even the way marriage licenses were approved was based on the eugenics and the lack of science that was in that particular study that was used for so many traditions, so many customs throughout the United States. Let me take a pause for a second and just ask if there are any comments or questions from anyone.
I don't see any.
Okay, thank you. So let's move on to residential services. And during especially the late 1980s and 1990s, and continuing until today, I have done a lot of international travel, national travel, and visited lots of closed and many that were not closed. There are still countries in the world that the residential services is the main way of providing care for people who can't stay at home. It's not that they don't try to keep people in the community, but there are still some that they feel are best supported in a residential setting. The physical environments may have improved, but in those days, I could see, I could hear, and I could smell an institution, and they all smelled and looked alike. They were horrible situations to live in. And I actually began in my days, let's see, I think this is the next one. Let me skip down to a photo. No, sorry, I'll go back up and I'll get to it. I actually started out in the Rome State School that looked very much in the way of the first picture. We see in the 1970s, the National Arc in 1971 recommending that institutions for retarded persons, remember what we say today is a horrible word and we can't use, whereas accepted terminology. And while I think language is important, I think it's also important, first of all, we understand that older caregivers today and many paid caregivers do not know that and it was actually only a few years ago that legislatively every state in the nation changed the legal terminology from mentally retarded to intellectually disabled. So there are people out there who still use the word, not intending to be insulting in many cases, just accepting that what they had been taught and what was the past was still acceptable. They found many institutions, which is true, were usually located in remote areas and characterized by inappropriately designed, overcrowded, and antiquated programs. It was compounded by the fact that most residential staff were underpaid, poorly trained, and often have little chance of achieving better working conditions or advancement. It is widely recognized that former concepts of custodial care are no longer acceptable, but this is a good description of what it was. This is the Rome Custodial Asylum for Teachable Idiots. This was the very first building that was built for that, and eventually this was expanded to a huge complex. I began teaching there in 1972, which again tells you how old I am and why this doesn't feel so far away. And at the time, it was felt that this was the best placement. Now, I began when it had been renamed Rome State School and was working when it was renamed to Rome Developmental Center, and then became the Rome Developmental Disabilities Service Office as deinstitutionalization continued. And this whole facility at some point became a prison because it was considered to be, much of which now is closed down, but there's still parts of it that are still open as a prison facility, especially a prison facility for people who are medically frail in the prison facility. And here we see this as a postcard. These were also places that were visited from all over the world. The Rome State School was known for some of the best care, and they literally had summer school for teachers around the world to come and to learn how to teach people who were educable, trainable, or profound. Though profound, it was felt even in school. It was, and there was at one point where the level of intellectual disability determined if they could even go to school. And remember, mainstreaming and people going to school, the Education for All Handicapped Children Act is not until 1975. And so school districts could literally say, we don't have any place that, and any expertise or people who are trained in this, no teachers. And so often these were the children who were placed in places like the Rome State School. If you haven't seen, I can remember when I was director of staff development and training, and every year we'd recommend what should be the mandated training for staff. And there was always a day of mandated training that was required in those days. And I strongly went out that Willowbrook, the last great disgrace, should be one that is mandated and viewed, and we should be discussing how we don't go back to institutionalization that we learned from this. And it took going to the Board of Visitors to get permission to teach this, because it was felt that was old news. We didn't need to learn that anymore. We needed to move on and look at the future. If you haven't seen this, you should. And I don't know if anybody still mandates this for seeing or even shows it in training, but I think it should be considered essential. Now, remember, this took place in New York State. And so deinstitutionalization in New York State came very early in the process around the country. However, becoming part of the Medicaid waiver program, New York State was one of the last to participate in that, something like 45th in the nation to participate in a different way of funding, a different way of providing services. If you haven't seen Refrigerator Mothers, it's you need to see it. It's very difficult, I warn you. I teach a class, Aging and IDD, online for Utica College, which used to be part of Syracuse University and now is its own private school, college. And I do 2 or 3 sessions that I actually have them view this, because it is extremely difficult to watch it fully. But it really was Bruno Betaheim and Leo Kanner who defined what infantile autism was, and that it was not that the children had any problems or brain damage. It was that mothers were not nurturing enough, At that time, they were typically mothers who often worked outside the home. They might be college professors. They were often highly educated, middle class or upper class, and out and working, and they were often blamed. In fact, to the point that they institutionalized the children, and the mothers were never, or any of the family, but especially the mothers, not allowed to go in and see their living conditions, their bedrooms, where they slept, what they did during the day, because literally they were going to pollute the environment, and they will bring back the lack of nurturing that they had failed at, according to Bruno Bettelheim and Leo Kanner, who made a huge career out of this, became fairly wealthy and certainly internationally well known. This is the origin of how we think about people with autism, and also how we think about mothers of children with disabilities, especially autism. As we hear is JFK, and this is Rosemary Kennedy, who was extremely beautiful. She may have been very mildly intellectually disabled. However, there were lobotomies and all kinds of things practiced on her. And so by the time she really was placed in a custodial institution, she was no longer functioning. And part of it, there's a wonderful book about the Kennedy women. It's very long, but it really is an eye-opener. They were afraid, because she was so beautiful, they were often getting offers of marriage for her or for dating, and they did not want her to be dating. They worried about pregnancy for her. And so they tried other things that they hoped would, and again, it was in good tent. The Kennedys have done so much to actually, they're the start of the National ARC system. And so they really started the federal attention into the poor conditions for people who were mentally ill and mentally retarded. And this is a quote from John F. Kennedy in 1966: "To the grim mercy of custodial institutions too often inflicts on them and on their families a needless cruelty which this nation should not endure." 25 years ago, residential services included birth to death, segregated from the community. So much so that they're literally, and I also saw this in the UK. I was given a tour of facilities in the UK and went to the institution, which had not totally closed down. And there was a cemetery that had beautiful flowers, sat in front of this beautiful chapel on the grounds. And then there was a fence behind with a cemetery that rarely had any markings. When I asked why the difference, what was the other cemetery, and they said those were for people who died indigenous in the institution. These are for people mostly who worked for the institution or who provided supports to the institution. So segregation in every aspect of life. And we know from social isolation that we've experienced in the past year. Hopefully, for me, I know going out into groups, I sometimes seem to feel like I'm going into panic, to anxiety, because if I see someone, do I ask them first if they're vaccinated and then ask, can I hug them? How do I approach people? Is it allowed to shake hands? How do we, and people feel other than us because we've been so socially isolated from others. And even as we did institutionalization, here is the difference. Persons with mild or moderate disabilities considered for community placement. To also understand, by the time deinstitutionalization had occurred, there had to be repartition. I'm sorry, pronouncing tonight word probably wrongly. People had been moved. For example, Rome State School was one of the largest institutions in the country at one point, and in the world. And that's because people from all over the state were brought to there, and it was built to be the largest in New York State. And so they were separated at young ages, from often sometimes even at birth, but certainly in infancy. And there were also women who were institutionalized. There was a ward in many of the schools, and there was at the Rome State School, for the mothers of the children who gave birth, because obviously they were raped in the institution. Horrible, horrible conditions. And many of them also placed in community settings where they might come back when they became pregnant, those that were considered very high functioning and could be working girls, was often the word used, to go to cook, clean, and take care of children in the community for families. Understand that the built physical environment is a direct visual example of our society prejudice and stereotypes. If you look at how impregnable the buildings look of institutions, that tells you what people thought, and the fact they're out in isolated rural areas, separated from the rest of the community. They may not be today, these buildings that remain, because the cities may have grown out and built around them, but when they were originally built, they were. The community was mostly inaccessible for people with physical challenges. Remember, the Americans with Disabilities Act was signed into legislation July 22nd, 1990. I believe that's 90. But there were also a major business opportunities for consultation on how to get around the act. We're better today, but no enforcement was ever built into the act, and it's been a slow change and not fast enough, obviously, for the physical environments we continue to live in. So let's look at medical care and IDD. Laura and Kim, I assume if you see any comments or questions, and hopefully there are some, or hopefully you're starting to build the questions you're going to ask about how we build the new normal, the tomorrow.
Right, there were just a couple comments in here. One from Jen at Schenectady ARC. She said, and this is back from when we were talking about the state schools, ironic that they commented on staff being underpaid and undertrained back then. And here we are today, once again, facing the same fact.
Yeah, and we're also facing the fact that though it's been tried to build into the infrastructure bill, that's been the most debated, that caregiving and human services and providing care isn't considered infrastructure, when we've learned in COVID it's essential. We can't survive without it as a society. Yeah, totally true, Kim.
And then Schenectady ARC and new employees at OPWDD still see the Willowbrook video. So there were two comments about that.
Good. Well, then in OPWDD, I was one of the people that made that happen. Certainly in Rome, but it became part of orientations around the state and recommended. So they should be very proud of it. And hopefully you're still allowed to ask the very difficult questions. I've always been concerned it can be one or two people, depending on who has the decision making, who sets the habits, the routines, the standards that can make an institution. It's not numbers alone. It's the physical environment, it's the social environment that does it. We need to keep asking. Great, thanks.
And then Fred is on. Fred from Third Age Committee said that his first job in 1979 was placing people out of Willowbrook into residences in Brooklyn.
Neat.
Hey, Fred.
And I didn't know that, Fred. Knew a lot, but didn't know. And we need to not forget this history. And we certainly need to make sure that it survives, and that we don't accept what is today. As we've reached there, we're nowhere near where we need to be. And COVID-19, again, there are always gifts, even with the most horrible situations. The gifts have been to open up our eyes to see the healthcare disparities for so many people around the world. And in the US, where we try to say we have the best healthcare in the world, we only have the best for those it's accessible to. And that's certainly, and we've learned how much we rely on our caregivers and the sacrifices that people made in human services and made in the IDD field. I've never been so proud to be part of this field. So, and Fred, you were one of those that helped make that happen.
And that's all the comments for now.
Okay, great, thank you. And please keep doing that. I love the interaction, and hopefully this is being meaningful and not just feeling like an exercise to do. This is where I found really fascinating: pandemics and the survival of the fittest. Eugenics movement was very much part of what we call the Spanish flu, which really wasn't the Spanish flu. It's similar to what's happened with COVID, and people trying to blaming China for it. And some people calling it the Chinese flu. Well, the same thing happened in the 1917 and 1918. It was the immigrants who were coming in from Spanish-speaking countries that they felt brought the disease into the United States. And also that those who were not the fittest, those that the eugenics movement were trying to make sure were sterilized and not able to continue to reproduce, it was thought to be, they were bringing this in. And remember, 1917 and 1918, just getting over World War I and the horrors, or certainly 1918, of people returning home. And that was the other thought, that the military returned home, got this in those countries, especially Spain, and brought it home into the country as well. So it's all of this is related. Book titles in the 1920s: The End of the World, Social Decay and Degeneration, The Need for Eugenic Reform, Racial Decay, Sterilization of the Unfit, The Twilight of the White Races, which also has a component in COVID-19 today, and has a component in our healthcare and certainly in our political system right now. So modern medicine and society. This is medical and custodial care of the past. It has not been that long ago. This is when I started to work in the Rome State School. At first I worked in the school building, but then I was placed out into some of the buildings, and buildings looked very much like this, actually not as neat. This was cleaned up and made to look neater for the photograph. And you can see this is New York State Institution for FM as feeble-minded children. And this was Syracuse, which has been closed down to this day. And institutions are institutions, and often for people who are mentally ill, people who had epilepsy, people who were called moron, imbecile, idiot, all of these were mixed populations of people, because there didn't have to be, there was no bottom or no line for who could be placed there. It was very much related to the families themselves. I had a very good friend, Henrietta Messenger. She was one of the top advocates in the country. She was older at the time I met her, and she was, is my age now. And she had been instrumental in creating the National ARC Network, and certainly in creating the ARC Network for New York State. Her daughter was her last daughter. She had 8 or 9 children. I don't remember the exact number. And when her daughter was born, her doctors told her, you need to institutionalize her. And she said, but she's just another child. She's like all my other children. And so she went out and visited these institutions they wanted to place. And she came back to her doctor and read the doctor a riot act. How dare you? How dare you recommend this is where I place my daughter? This is where she belongs, and it's for the best of everyone. And she asked the doctor, have you ever visited there? And the doctor admitted no. And so then she said, so I kept my daughter at home, and I helped develop the residences and programs for those families who could not, for those families to help them advocate so we could make better living conditions. That was the ARC movement. She said, so I developed this, but I kept my daughter at home, and I encouraged every family who could had the supports, and we tried to make sure mainstreaming, making sure education was available to everybody. And so we worked on from childhood to middle-age adulthood, because at that time people weren't living, especially people with Down syndrome, to old age. And she said, then they came to us and told the families, we've now decided living in the community is better. So let's put people out in the community. We're going to deinstitutionalize. And by next week, we hope you'll be able to take your children back. And many families didn't know what to do, just in a panic. And so Henrietta's last, and this was one of the last presentations I did with her. Now today, you're telling me that everyone should stay home. There shouldn't even be residents in the community. And you told me my daughter wouldn't live to be to old age, and my daughter is still living to old age. And you told us not to take out insurance and not to do long-range planning. And so every step of the way, the experts and professionals advised the families what to do, and they've been wrong. And even when they're wrong, they don't come back and apologize. They just say, this is what's known for best for today. Here's an 1800s operating room. Leeches is one of the major forms of treatment. And understand, infection control, which is obviously one of the major issues in COVID-19 and other COVID-related or flu-related illnesses. Infection control, actually the person who did the study was in Vienna, Austria. It was Dr. Semmelweis. Semmelweis was considered one of the top surgeons in the world. And people came from all over the world who had the resources for surgery for childbirth. It was going to be a difficult childbirth. And oftentimes the studies were done, by the way, on the poor children, poor women who could not afford midwives or could not afford to have their own health care. And this is as midwives were really being condemned, that they would come there and they would give birth. And one day, Dr. Semmelweis, in a large academic meeting, stood up and said, I know we're considered the best surgeons in the world and the best deliverers and helping women who are having difficult childbirth or other childbirth related surgeries. But guys, we're losing our patients within weeks, days, weeks, or months after. And so there's something we're doing wrong. And I think it's because we're using the same instruments, we're using the same rooms. At that time, they didn't even change the sheets in the operation rooms. And they would have hundreds of male interns who would be there, no worry about infection at all. He was actually laughed out of the medical society and ended up in, at the end of his life in a mental institution because they thought he was crazy, that he was blaming them for the deaths and the infection. Many years later, we know he's right. An invalid's room. And midwives provided care, but were not considered physicians and became outlawed, especially became outlawed in many religious movements. You will find in Salem, in the burning of witches, women who were midwives were particularly vulnerable because often midwives had a lot of power and respect in communities, and they were often paid with goods, and so they were able to support their families, and sometimes even with land if someone was grateful. And so it was also about that they were developing too much power and too much ownership. And understand when the male medical community took over childbirth and made it illegal for midwives to practice in many communities, it was at the same time a male doctor could not touch the female patient. And so these literally are very, very valuable antiques today. But a woman would come in and she would point out what parts were bothering her. And so it wasn't until, and even then it was by instruments in surgery, that the doctor would be operating on her, but was not allowed to touch her in the office and really couldn't do a thorough examination. And there, by the way, are documented physicians who hired midwives for the birth of their own children because they didn't trust the system that they were in. Modern medicine, as we think of it in the US, began about 1920. When they thought they had all the treatments that would work. And that was when they began really charging for these treatments. Also still a time when women were not allowed to practice medicine. Very few women allowed into medical schools. And if you read the history of those few who were, and there were also during the Civil War, for example, women who were practicing physicians, but they could not be recognized as such. And often those who came along to take care, tend to the sick, the ill, those that were injured, were called camp followers and often accused as being women of prostitution, women of ill repute, instead of being professionals who were there to try to treat and keep as clean conditions as possible. Modern insurance really began about 1940s. And it grew substantially, and the workplace became the place for healthcare provision and benefit. And by the way, what was considered healthy and how you were charged for life insurance or healthcare insurance was based on measurements that were old, often falsified, and measurements that may have been gathered in the 20s and 30s that were used as guidelines. And some of these still used today without being changed. So let's look at aging in adults with IDD, what has changed in the past 20 years, 25 years. Laura, any comments?
Not yet.
Okay, good. I'll try, not good that there aren't, but I see I have 10 minutes left, and we wanted to make sure to try to leave about 15 minutes. So hopefully all of you will be having comments and discussion. There have been changes in medical services over time. Article 16 and 28 clinics. Now we're looking at telehealth and echo, all kinds of new opportunities, but we are anywhere near trying to correct the healthcare disparities in our system. Aging today has changed from what was considered a disengagement theory to activity theory, that people need to stay engaged in life, in their communities, and with others for healthy aging. And again, COVID-19 has certainly proven to us the importance of how all those connections are and how important that we're all together. However, today still, including residential, still one of the last institutions to close are those for people who require intensive medical care who are older. So has the medical model really changed? Not really, if you look at it. And often how we look at still using the medical model even for placements in residential facilities. This is aging and Down syndrome 25 years ago, though this is not how people were dressed. These were people who were lined up for a clinic. It was a training clinic, and this is where people came from all over the world to attend these. And would learn about people and treating people with Down syndrome, and would ask questions, and literally people put on display for those questions and talked about as though they weren't even there. I still find today case reviews, meetings when the person is there. I have a very difficult time. I want to talk honestly, but I don't want to scare the person. So it's always a challenge. At home with families in the community, a goal versus Erik Erikson theories. Many of you have heard me talk about that we base our theory of the importance of independence on Erik Erikson, who had stages of life and what were the responsibilities of stages of life. You can see the psychosocial crises chart that is Erik Erikson's stages of psychosocial development. He considered old age to be a horrible time and didn't even want to consider that it should be a disengagement and a time of just trying to be away from others. And he had his fourth child was a son with Down syndrome, who he was told to institutionalize, and he literally did. And they did not tell the family. His sibling, his sister, the son's sibling sister, wrote a book, In the Shadow of Fame, about the institutionalization of her brother and her never having met her brother by the time she learned of his existence. It's a very telling story. If you haven't read this, I really recommend you do, and think about what does this mean for today.
Kathie,
please.
Hi, we do have one question. I don't know if you want it now or if you want to wait.
Sure, go ahead. Okay,
it's from Fred. Can you address the effect of isolation, COVID related, and how it may affect individuals with IDD and dementia.
Well, so especially people with autism, for example, we know have sensory problems and have socialization problems to begin with, being close to people, being touched. And we've spent so much time teaching people to be able to touch others appropriately with shaking hands, a hug if it was a family member or someone who felt comfortable with a hug, going in the community and being in crowded spaces. And now just the opposite. And we've taken away every habit, every routine for each person. And now to explain it, we had to make that it was dangerous. There was infection in the community. We can't touch others. We have to try to wear masks. And so we can't, if we understood what smiling and what frowning was and what facial expression, or that someone was happy or not happy for you to come in so close to you, with the masking, in addition to social isolation, and people who may have difficulty with cueing, of cues, facial cues, body language. All of this has removed people from this, and now seeing that people are afraid to go back out into the community. Now we've seen some positive spread. We're all realizing that maybe multitasking, being in the community 12, 14 hours a day in groups of people isn't good for any of us, especially for people who may live, work, and socialize, do recreational activities with the same people 24 hours a day. And so we know there needs to be some, not social isolation, but some being in the moment, being close, being with yourself and being able to be still. But we also now are going to have to work through creating new routines that will feel comfortable and safe, and for people especially to feel safe in the community again. And I hear many people, it's not just fear, it's also they don't want to go back to crowded conditions to do activities that are based on a school model of the past, the 6-hour day of the day program. Very brief, that's it. We could, in fact, I've done a webinar, be happy to do again, just on how COVID has affected habits and people's ability to function. Happy to do that in the future as well. That's a very short, brief, not well done, but, and this is all part of the social context. Life expectancy, one of the reasons life expectancy for people with Down syndrome was because they became part of the community. They weren't isolated in infection-ridden institutions in huge, huge rooms where they slept together, ate together, lived together, had 20 minutes for meals. And here we are back to doing this. It may be 10 people in a home, it may be 6 people in a home, but it's back to an institution setting. That's another thing that social isolation has done. And many places around the country have not returned to doing community, going out into the community. And it may be many, many months, especially where the infection rate is high. But what will COVID-19 do? Social isolation certainly being part of it. We know that healthy aging means having a social network around us. What isolation has done for all of us is destroy the social network that we had. We have to rebuild it. And for people who have difficulty building a social network to begin with, other than the people that they live with, becomes really, really problematic, and something we need to make sure we focus on as we build the new normal. I'm going to skip down because we're getting towards the end. I do social integration. Has never ever been achieved. We certainly have become part of the community, but not part of the community in every sense and every way. And so think about that in building the new normal. The average longevity, early 70s, this appears to be true for the less severe, the intellectual and developmental disabilities, the more likely it'll be a longevity similar to the general population. Though I suspect after COVID, we are going to see a great reduction, and that's going to be for a number of years in life expectancy for all of us. We know that for people with Down syndrome, they've been particularly hard hit by COVID, and we know for people with intellectual disabilities as well. New York State, I was fortunate, Fred, you were fortunate as well. We were in the state that was the leader in the world for deinstitutionalization and creating a new field of study, interest, and interventions for aging. Third Age evolved out of that. And Laura, you've been part of Third Age for many, many years. I don't know, it might have even been in the beginning when you were doing your internship with TPAD. Laura, were you?
Oh, I just said maybe. It's been a long time.
Yeah, it's been a long time. A Third Age might have been there. Jenny Overrinder, who was the first director of the training program in aging and developmental disabilities, started Third Age with initially a focus on people with cerebral palsy, but then expanding beyond that. Today, we've developed parallel systems. We have networking between, but not enough. And we need to think about, because it does take a village, it does take all of us together. Understand that 25 years ago was when it was actually in the 70s and 80s, when the initial studies, which were cross-sectional studies, not longitudinal. And it is true that the pathology, the plaquing and neurofibril entanglements that are the underlying precipitator of Alzheimer's disease has been found in close to 100%. I think they've one or two that were autopsied after death that may not be the significant amount of the plaquing neurofibril entanglements. So we know that pathology is there, but we also know that the symptomology of Alzheimer's disease, that there are people who do not exhibit it with Down syndrome in their lifetime, and the life expectancy has gone up now to around 60 for people with Down syndrome. And that's one of the reasons, just simply understanding that it's not 100%, and we need to do differential diagnosis. We need to make sure that we're ruling out the underlying causes for decline. We're also, I had many, many stories when my dissertation was on caregiving of adults with IDD in the 1990s. And the families who had a family member with Down syndrome would tell me story after story, and it was all the same story of how doctors refused to treat their son or daughter, their sister, brother, and how hospitals, literally they had to hospital shop because they would say, no, there's not a quality of life. You just need to let your child go. And this would be for respiratory problems, which could be very easily treated, and also for cardiac problems and other illnesses that in the general population would have been treated, but would not for children with Down syndrome. And we're very disparaging to families. Henrietta talked about the situation as well, in many times in presentations when we did them together. We have better accessibility. We need to know reductions in Medicare and Medicare will increase healthcare disparities already experienced by people with IDD and their families. And something else to consider, because we live in a northern climate, and I think many people on the webinar do, understand that if your families are deciding to move to other climates, to warmer climates, and want to plan their retirement years there, they need to make sure that they contact the disability organizations, the DDPC in that state, to find out what services are available. Medicaid is not transferable from state to state, and in many states there has to be a re-diagnosis, and in some states they're not eligible for services, and the only time they become eligible would be after another diagnosis, but also would be placed on a waiting list, which in many states, Florida and Texas, I know, have tens of thousands of people, and the only time you move up to receive the services is when it's in crisis. And if you're living with a family member who has moved, who has the assets to move, that's not considered crisis. I've met many families that have gone bankrupt because of this. We have learned it does take a village of caring for each other. Recruiting caregivers will initially be more difficult, but we did find some people actually liked being at home, and that we need to slow down, and we need to also, in terms of recruiting caregivers, we need to stop demanding the multitasking, not expecting that they can do all and everything all at once, and find ways we have support and we slow life down to be a reasonable. We can't burn out the caregivers. Movement and socialization is essential to health. That's part of social isolation. people did not move. I'm finding myself when I'm out driving, and I even when I did go out, often it was with my husband who drove. I did nowhere near the amount of traveling and movement, and I find myself, I've forgotten some of the routes. And this can be true of just figuring out how to go into a program area that you were very familiar with before. And so this is another downside. We've also learned that a day in bed to 2 days literally can reduce our muscles and our joints are where the most cells for receiving the sensory information that helps locate us in place or in space. And what happens is that it can take many months, even just after 1 day of not moving. And so it's essential that we reteach movement and helping people locate in space. We've learned that grieving together is essential for our healing. Give each person, including yourself, the time to grieve. This has been a very, very difficult time. But also understand, if we're frightened to go out, we're invited to a wedding and we're not sure everyone is vaccinated. We have underlying conditions, and we have to question it out to decide whether to go. Think about how it is for someone with intellectual disabilities who may not cognitively really, and many of us can't cognitively still understand what happened. And so give permission for grieving, find ways to do grieving together and to honor that grieving. Environments need designing and modifications even more, and making sure we're designing to promote movement. By the way, this whole concept of human services being not-for-profit, voluntary, has been set up, and it's set back when the gross national product was first developed. And there were discussions about the work that women did for caregiving, that sewing they did, house cleaning, the things they did. And it was intentionally decided that that would not be considered part of the gross national product. It was not considered productivity, and this is why we are paid the way we are in the human services field. For those of you who know us that always say that I think we should be paying small stipends for people for doing events and activities, because of this concept, we need to move away from human services always being those things that should be voluntary, and to understand they are essential for the functioning quality of life for any society. The lesson learned is be a critical thinker. For my dissertation, for my defense, I had to defend with a stent in. I had kidney stones being removed, trying to be moved. I had to put a stent in to try to move. And so I defended my dissertation, which is on older caregivers of people with IDD and adults and older adults. And so after going through this in significant pain, as well as just so nervous, sat outside for about 20 minutes under a model, and I think I have the photo of this. Yes, I sat under this particular portrait. That's not me. I happened to find this photo online. And this quote, which I will never forget today, as I'm sitting there waiting for someone to tell me either I failed or passed. And they make it has to be at least a half an hour, if not 45 minutes, that debate goes on. They have to keep you really in stress during this time. And so I kept looking at this and have it memorized. The one thing that is certain, what we do today, we will regret tomorrow. Dr. Burton Blatt, who really started deinstitutionalization and mainstreaming and changing what education, and was part of the Education for All Handicapped Children's Act as well. It's important we think about this, and don't think that we want to redesign to go back to what we did before COVID. We really want to look to what we can do for tomorrow. Happy aging is staying engaged. It may not be. Now, for me, this would be a nightmare to be with all these people and lots of noise. I want quiet. I like to go out to dinner with 3 or 4 people at the most. But it's what it is to the person. And so we need to look at that balance between social isolation and being together, but being able also to celebrate together and understand we're going to have to support that because it will not be something natural. It's not natural to us. It's not natural to people whose entire routine in life has been turned upside down. Have passions for yourself, for things in later life. It's why I never know enough to retire, because this is one of my passions, advocating and making a difference. So I open it up to comments, questions. Laura and Kim.
So we just had a comment in the chat from Judy, who said she has a friend who has an adult child with Down syndrome that's been told she has Alzheimer's automatically. And Judy asks, is that still going on? And Judy, I'm sorry, I didn't know if that was a rhetorical question, like, really, is that still going on? But
Yes, it is.
Kathy, I'm gonna let you.
I'm actually have been fortunate enough to have become part of a 5-year grant, state grant for the state of Texas. And I just came off a meeting just before this with the planning group. We're going to develop telehealth and echo around the state of Texas and try to break down those barriers for healthcare access. It's so exciting to be able to make this difference. One of the discussions we just had is we're seeing in practice, anecdotally, 80 to 90% of the people we're called into work for have a diagnosis of dementia. There's been no differential diagnosis done. Diagnostic overshadowing is happening. This is happening around the country, every state we visit. There are some that are a little better, but yes, this is happening. And with COVID, I guarantee it's going to be worse. In medical schools, do not teach IDD in medical schools. What the few that do, the rare exception will usually be maybe a 3-hour lecture on Down syndrome and the higher risk for Alzheimer's disease than the general population. And busy healthcare providers who also are in shock from COVID-19 don't have any more time than they did before. So one of the good things that's happened is insurance companies now cover telehealth. And so maybe we can build that telehealth to do what's done with ECHO, which is to have a team of knowledgeable people who can give advice of what to look for, what should be conducted in a differential diagnosis, and to work in partnership with the healthcare providers. So unfortunately, Judy, yeah, it's still happening. And no one, regardless of their pre-existing condition or diagnoses, should ever receive after 1 or 2 visits a diagnosis of Alzheimer's disease, or even the general terminology dementia, which is not a specific diagnosis. And all of us need to spread that word and continue working on that. That's again why I don't retire.
We're glad you haven't retired.
I am too, though there's days, Kim.
Oh, I know.
You've been doing this almost as long as I have. Not quite. You're
Not quite, but yeah, 30 years. It's
yeah. I've known you, I think, as long as I've been working in the aging field. Laura, about just as much as well. And by the way, I need to update that bio. It's actually over, I think it's over 30 years now. I've been aging in IDD rather than just IDD. I have 5 minutes left.
Okay,
Laura,
so Judy just added a little bit more to the chat. She said this family lives in Pennsylvania and went out to lunch with her and her family in 2018, and she's known her since birth, and she recognized all of us, had no problem picking out what she had to eat. Judy doesn't believe that this woman has Alzheimer's, so she needs some ideas to help with the family's understanding of the issue that she does not have Alzheimer's.
Yeah, give me, Judy, get Laura to give you, I have the email there. I also have an NTG email. If you would send that out, are you going to send out the PowerPoints?
Yes, I will send out the PowerPoint.
Contact information. We have quite a few. Pennsylvania is one of the better states, not that it's, it doesn't happen there, but I can give you some resources, and we can also discuss some tips for the family as well. So please contact me after this. This is what I love to do the most, person by person, try to make the difference. So please do contact. I'll be happy to give you some tips and some contacts in Pennsylvania to help the family.
Right. And this is one of the areas where Third Age is hoping to build up our website and to have some of these resources handy, so that when you have, say, a healthcare practitioner or a family or a provider in the community that doesn't know about Down syndrome or doesn't know about any other issues, you could just go to our website and we'll have some quick links there that you can pull and share with other people.
Yeah. And Judy, if you haven't gone to the NTG site as well, things like the Thinker document, there's a healthcare advocacy article I was the lead author on. There's some really good tips there. I would advise anyone to have those available printed out, or the link at least available for families and family advocates to be able to access as well, because there's some good some good resources there. My dream with NTG is like certainly combining, and third age will be one of the resources. We're hoping to be able to do it state by state so people know automatically, and not that you can't ask because third age is in New York. I know this group, they'll help anyone from any state.
Absolutely. So Kathie, I know we're almost out of time. I don't see any other questions in the Q&A, but I do want to thank everyone. Oh wait, we just got one. All right, this is from Ruth. Hi, Ruth. And we are tracking long hauler symptoms with individuals with IDD. This is COVID, obviously, with the long hauler symptoms. Are there any other agencies doing this and any research on this? We want to see people with IDD get the same treatment for symptoms as the general population. Excellent question.
There's an excellent question. I know NDSS. I know NTG is talking about, a number of NTG members are members of other organizations. AADMD, the American Academy for Developmental Medicine and Dentistry, is looking at this. And so, yes, there's active discussion. I'd have to contact me after, and I may be able to give you some other links to that as well. And I know we've talked about doing it with families, and it's something we're also talking about with the work I'm doing with the state of Texas. So I'm sure there will be, and it would be great to be able to connect all these groups. So please contact and think how. And stay in contact. Third age, certainly we need to talk about how we can stay in connection. I'm a third age member as well. So we want to figure out how in New York, but also connect with what everyone's doing.
Just with that, because Ruth, you're on third age, Kathie, you're on third age, maybe this needs to be a subcommittee where we pull all these resources together.
I think it does. We, for example, in NTG have a meeting July 5th to talk about, and I won't pronounce it right, andenum. Can you pronounce the latest?
Oh, adumanicab, the newest Alzheimer's medication.
Yeah, I've seen it a couple of different ways spelled. So yes, be very careful. We're needing to figure out the position. There's a lot of indication there was falsification of data. This is based on old data that they changed around to get it approved. There were 3 members of FDA who quit because they didn't feel the data was accurate to be using it yet. It cost $56,000 with all the tests to have it. People with D have never been part of trials, especially people with Down syndrome, who always tend to have a very high sensitivity and a very high rate of interactions and unwanted effects from medications. But there are families out there already agonizing. If I can get together the 56,000, maybe if I sell my house and maybe have it, will it help? And we don't know. And so we're trying to put their position papers that organizations, national organizations, are trying to put together to slow this down a little bit and look at the research. It's not even, we really think, the right thing for people in the general population yet.
No, it's only got a provisional approval at this time.
Yeah.
So
and even that provisional approval caused people to quit because they felt it was too soon. The data had been too messed with, and there needed to be better clinical trials.
Absolutely. So we can send out some information about that as well.
Yeah, and I'll be having more. This is again where we can share with third age, and I'll try to make sure those resources. For example, I have no problem sharing that healthcare article with. So as we build the website, let's see about adding some of these things, Thinker document, those kinds of things, or at least the link to them.
So with that, we are now definitely out of time. But thank you so much, Dr. Bishop, Kathie Bishop, I've known for many years. And thank you, all of you, for taking time to join us today. I do want to say there will be a quick evaluation survey that opens up when you guys leave the webinar, and we will email this out to you as well as the slides and some of these resources that we talked about. And we do hope you'll join us for our conversation next month with Dr. Jean Kerwin and Jane Boyle, discussing medical ethics and people with IDD, and that'll take place on Thursday, July 8th. So thank you, everyone. Enjoy the rest of your day, and we will see you next month.
Thank you, everyone.